Well, hi there. It's good to see you right here on Health Diary. My name is Winnie Lubembe, and today we're coming to you from the Aga Khan Hospital. So with over 2.3 million new cases of cancer across the globe each year, there is dire need for screening and diagnosis. But the bigger question is, what types of screening should we be doing? Well, today on the show, we'll be focusing on mammogram. What is it? Who qualifies for a mammogram? And what is the procedure like? Well, come with me. Let's find out after this fact of the matter.
Breast cancer starts when abnormal cells in the breast grow out of control and form a tumor. If unchecked, it can invade nearby tissues and spread to other parts of the body. The earliest forms may be in situ, meaning they are confined to ducts or lobules and haven't invaded surrounding tissue. Invasive cancers have spread beyond. This is according to WHO. It is also defined as the most common cancer in women in many countries. Though all countries are affected, survival is much higher in high-income countries compared to low and middle-income ones.
All right, well, let's get to understand mammogram. But before that, we'll take a look a little bit about the recent trends when it comes to breast cancer. And to help us with that conversation, we have Dr. Rose Ndumia, who is a consultant breast radiologist right here at Aga Khan Hospital. Thank you so much, Dr.
Thank you.
Sparing your time. I know, crazy schedule, busy schedule.
Yeah.
But first things first, can we just understand breast cancer, say the recent trends that you have seen, and even just from the screenings and probably diagnosis that you've done over time.
Yeah.
What is it that you've noticed? What is it that you've seen here in the country and also across the globe?
So first of all, a warm welcome to you. It's nice to have you here. We really like to promote, breast cancer awareness in the public domain. And when it comes to the trends that I've seen, one good trend I've seen as a radiologist is the decrease in the size of tumors that I see. When I did my breast imaging training and came back in 2017, which is roughly about 8 years ago, I used to see patients with large masses, like bigger than a golf ball. Some would have wounds which were oozing and quite smelly, and that would be the picture of what a patient presenting with symptoms, which eventually diagnose a breast cancer, would commonly be. Now, as there's been more and more breast cancer awareness raised, and as more women take up screening, the smaller and smaller the size of tumors that we're getting. Because you can imagine if at all, let's say someone came for a mammogram in 2020, it was all clear. 2021, something developed that when I compare with the 2020 mammogram, now there's something that's come up. It's going to be a very small finding. And there are times you'll find lumps even as small as 1 centimeter, that even sometimes the patients will tell me, but how come I can't feel it? And I've checked and I can't feel it myself. And I tell them that's the beauty of mammography.
Are you then a bit concerned because then you see the more the masses are decreasing, the more it becomes complicated to even notice in the early stages? So
the reason why I would attribute to us picking smaller and smaller lumps is just the uptake of screening. Okay. So instead of waiting for a lump to develop, people or women now are more aware that they need to come for the screening. And we see that even in October, the numbers really go up because also we subsidize the prices then. And many women are aware that they need to screen. And so as a screen and you have like that regular interval of 1 year, then it's very easy to pick up something. Something would not have grown to like 5 centimeters within a year. And even if it grows to the point that you feel a lump before your next screening, then you'd come back and you'd get examined, the imaging workup would be done, and the diagnosis would be established. So I think it's that public awareness that the screening, the availability of the screening services as well, as those have become more available, then people are being able to take up the screening, and so we pick them up.
So when we talk about breast cancer and screening, can we talk about the different types? I know for this episode we'll focus on mammogram, and then on the next episode probably do ultrasound and a bit of biopsy. But what are some of these other screening methods that are available?
So first of all, to talk about the most common breast cancer subtype, the commonest worldwide is what's called invasive ductal carcinoma. So that encompasses about 85% of the breast cancers that we diagnose. The next second most common type is called invasive lobular carcinoma. That takes up almost about 15%, and then we have the remaining, we call miscellaneous, less than 1%.
Okay.
Yeah, so that's what we'd see in terms of the makeup of breast cancer. I would want to say that lobular is a bit harder to diagnose.
Okay.
So now when it comes to the screening methods that we have, so you have many ways that you can detect if someone has a lump, yeah? So you could go to a doctor, they do a clinical breast examination, and if there's a palpable lump, then they will be able to tell you that they've identified something. But then picking up a lump doesn't tell them which kind of lump it is, yeah? So that's what we call a CBE, a clinical breast exam, and it's done by in our breast clinic. The next thing that a patient would be sent for, or even a woman would just present themselves and say, is that they want to do a screening mammogram. Now, screening mammography is the gold standard for you to be able to pick up breast cancer early. So with any screening effort, be it breast cancer, be it cervical or lung cancer, you want to catch the disease early. Yeah? That's what makes a difference in the long run in terms of the outcomes that you'll have and even the chances of mortality or death from the disease itself. So when it comes to screening mammography, it's a worldwide gold standard for screening. The same way that if you're asked, like, if I want to diagnose a cervical cancer, then you'll be talking about the pap smears and the HPV testing. When it comes to breast cancer, you really want to do a screening mammogram. In addition to that, and screening mammography now for average risk patients, because not everyone is at the same level of risk of getting breast cancer. So there are those women that you'll find have a mutation called the BRCA mutation 1 or 2, and those at a higher risk of breast cancer. So those are women that would be screened using MRI from the age of 25 onwards.
Do we do that here in the
Yes,
country?
we do have MRI in the country, and if someone is high risk, then their doctor would send them for the screening MRIs. Now, when that patient starts screening MRIs from the age of 25, when they cross to 30, we introduce the mammogram. And this is because mammography identifies what we call calcifications that you cannot pick up on the MRI machine. So when a patient does the screening mammogram, it could end there, that we find the mammogram is clear, there's no abnormality, and we release them to come back after 1 year. However, there are instances that you'll find an abnormality on the mammogram and you need it to be worked up further. So we go back to that patient we talked about. She had a clinical breast exam. The doctor palpated a lump, sent her for a mammogram, which we again identify a mass on the mammogram. But on the mammogram, we cannot be able to tell whether this mass is it a cyst where it contains just fluid, or is it a solid mass. So in that instance, then you need an ultrasound to tell you whether it's a cyst or a solid lump. And so it's very important for women to know that when you do a mammogram, sometimes you may be required to do an additional test, which will most likely be an ultrasound. Yeah, so ultrasound, I would not say is the gold standard screening method, but for women who are under 40, who are not at the age of screening mammography of 40 years and their average risk, then they can do just a breast ultrasound for screening purposes.
For screening purposes.
Yeah.
Okay. And then still on mammogram, I know there's a lot of fears, misconception, disinformation out there as far as mammogram. So probably just take us through some that you'd want to dispel here today.
Yeah. I think the first one is some women believe that if they've not had a history of breast cancer in their family, they don't need to be screened. And that's a misconception, because even amongst the women who, of the breast cancers that we do diagnose, you find a large portion of them don't have family history. And even the ones who have family history, it doesn't label you that you're going to get breast cancer. It's only probably 25% of those who have family history of breast cancer that would develop breast cancer. So I would say mammography is open to all women from the age of 40 of average risk. So because there's no family history, it doesn't mean you should not be screened. So that's one. The other myth that I came across that I found quite interesting was the women who have a misconception that mammography is like a vaccine, that once I've done it, there's a slogan that you hear a lot, that mammography saves lives, which is true. But it's not the same way like a vaccine works, that when you come do one mammogram, you're set for life. No, it doesn't work that way. You have to keep checking, because you don't know when that abnormal cancer cell will start developing and growing into the tumor. So that's why we say we check every year from the age of 40 so that you catch it early.
Pain is one of the things that we are very scared.
Yes, yes. And understandably so. I know that's one of the things that actually discourages a lot of women from doing mammograms. I have had women who have come and told me, I am not doing a mammogram, Dr. Rose. I am not doing. The last time I did one, I cried, I fell on the floor. It was very traumatizing. And I tell them, just give me a chance with you, because maybe one experience doesn't justify or does not say that that's the experience that you'll get with the next mammogram. So yes, with mammograms, we're going to squeeze you as we do the imaging. And that quizzing, maybe it's very important for me to explain why we have to do the compression. The breast is very mobile, and so if I don't compress this breast and it moves, that motion blurring will make it difficult for the radiologist to interpret your images correctly. So we really need the breast to be as still as possible. The second thing, by us compressing, this breast will become much thinner. And so the amount of radiation that you end up getting exposed to is lower than if we didn't use the compression. So it's helping even to lower the amount of radiation. It's helping the radiologist to make a more accurate interpretation of your test. And then the other thing what we do is that the way the machine is designed is that once the image acquisition has been done, it automatically releases the compression paddle. So you're not stuck there. So it's about maybe 10-15 seconds and the machine releases you. So it's uncomfortable, you'll be squeezed, but also the technologist who is doing the procedure, they will handle you with a lot of care. They will ask you, is that manageable? And it's a gradual compression. So you're not doing it all at once. You're going gradually, so that it's bearable. So we work with each individual patient. Another thing that can help a lot of women is, when do you schedule your mammogram so that you don't have so much pain? So if you come like a week before your period starts, then it's going to be a bad experience. So come the second week of your menstrual cycle. That's between like day 7 to day 14. You have the least influence of the progesterone hormone, which is what causes that discomfort.
And even aside from the pain itself, would you get the accurate, say, readings when someone comes, either, you know, when the breast is like swollen and painful and all those things? Does that impact the reading that you get?
It doesn't impact my reading because one of the good things with mammography is how it's evolved over time. So the days when I was training and I used to do cassettes, and then we had to take them to the dark room and process them, and then now look at the films. These days we have digital mammography. In addition to that, we have what's called tomosynthesis, such that I'm not just going to get a 2D image from front to back of this breast. It's going to create for me slices through the breast, and with those slices I'm able to see finer detail within the breast, because there's overlap of a lot of tissues within the breast. And so if you just do one image back to back, there'll be a lot of overlap. But with the tomosynthesis, and you're going slice by slice, even if you're how thick or how dense, I could be able to see if there's something there. So tomosynthesis has really helped us to improve the accuracy, and it doesn't matter whether you're in the one phase of the menstrual cycles or the other, you'll still be able to pick.
One of the things that a lot of people would ask is, first of all, do men get breast cancer, and can they come for mammogram?
Okay, very interesting question. And the answer is yes. Men do get breast cancer, but it's not as common or frequent like women. So probably less than 1% of the population will get breast cancer. However, when men do get breast cancer, because there isn't much breast tissue to work with, it can very quickly spread into the tissues around, like to the skin or into the chest wall. So it's very important for them, they'll detect it faster than women would, because there isn't much happening there. They'll pick it up very quickly, but then they also need to get it, the lumps attended to very quickly so that it doesn't progress. Now, other than breast cancer, there's also something else men get. There's something called gynecomastia. Gyne, like gynecology. So this is where men develop breast tissue in their breast, and it's usually just behind the nipple. So it can be a challenge to differentiate whether this is gynecomastia or is it a breast cancer? Okay. So in those instances that a man is noticing the breast is becoming larger or they feel a lump, it's very important for them to come for imaging because at that point we'll be able to tell, is it just the gynecomastia or is it actually a breast cancer? Okay. Yeah, and for gynecomastia you'll find the causes are things that could be reversible if it's picked up within a year. Okay. Yeah, and then if it's breast cancer, then we do the mammogram, we do the ultrasound, we also do the biopsies. Same way like we do for women. Yeah. The difference with men is that we don't screen them routinely. Yeah. This because again we see the incidence is very low. So when you're screening, one of the things that you consider when should I screen someone is when you have a high prevalence of the disease. Right. And so it's not high amongst the men. There's really no justification to use those resources towards that effort.
Okay. Density, okay? Yes, breast density, because a lot of people say, but men, there's really nothing. But
Okay. So when it comes to breast density, let me put it this way. In the breast, we have two main types of tissues inside. Yeah, you have fat, and then you have the fibroglandular tissue. Okay. The fibroglandular tissue is the glandular tissue that's going to produce milk when you're breastfeeding. So the younger you are, the more glandular tissue you will have. And when the glandular tissue is more than 50% of the composition of the breast, that's what we call a dense breast. Okay. Now, dense breast, when you do a mammogram, will look white. And when you're looking for a lump on a mammogram, it's also white. Okay. So it's very hard to look for white on white background.
And also that can be scary because the more white you see, the more you think.
Yeah, exactly. Yeah. It's actually a double-edged sword and I'll explain shortly. So first of all, you're having a challenge as a radiologist to find a lump because the lump is looking the same as the tissues. Yes. How do I differentiate the two? Okay. And that's where like tomosynthesis comes in, ultrasound comes in to help the women with dense breasts to make sure we haven't missed out something. Now the other side of the sword with women with dense breasts, it's actually been shown in research that it increases your risk of getting breast cancer. So here you are looking at a mammogram and you notice this woman has dense breasts. Okay. So in my mind, I'm thinking I really have to be careful with this
because the risk is higher.
It's higher that she might have a breast cancer, but I also know it's more challenging to find that breast cancer. And what we'll do in our mammogram reports, if you do have that dense parenchyma, every single report tells you what your breast density is. Okay. So that helps inform your doctor if you're dense or not. And if you're dense, we always recommend that you get an ultrasound done because the mammogram is not 100% accurate. You need to do the ultrasound to pick up if there's an additional lump that the mammogram missed out on.
But at face value, am I able to tell whether my breasts are dense? Because most of us would assume, oh, my breasts are big, so that means...
it would be hard to just judge, but sometimes you can tell with a clinical breast exam. Okay. It's a breast that you might feel is actually lumpy, bumpy as you're examining it. Yeah. And that's why we don't really recommend, like when you're examining the breast, to use your fingertips. You just want to use their palm. Yes. Yeah, because with dense breast, you feel that lumpy bumpiness and you're wondering, is this a lump? Is this a glandular tissue? So you can kind of tell, especially with the experienced people are doing clinical breast exams, that this is a dense breast.
But there's also something else that's when it comes to like disinformation, misinformation, myths, it's about bras and phones. You know how the way we like to put our phones, you know, over here?
Yes, yeah.
So we just touch a little bit on that.
Okay, So when you look at, so there are two things in the question that you've asked me because I've had myths from both. There's a myth that the phone in your bra is going to transmit like radiation and cause you to have breast cancer. The other myth I've heard is that by wearing a bra that has an underwire, or even a bra, some of them say, it's going to predispose you to getting breast cancer. And those both are falsehoods. Okay. So if you go back to your days of high school physics, there's something called the electromagnetic spectrum. So within that, yes, you do have radiation beam. So like even the microwave in your house emits a radiation, but it's microwave radiation. Then you have infrared, like what they use to sense temperatures in their airports, and you see a colored figure pop up on a screen. But when it comes to mammography and the kind of radiation that you're worried about is usually the ionizing radiation. Okay. And that's what you'll find now in radiology departments or in patients who are getting radiotherapy. That's the kind of radiation that we're worried about that can cause this kind of effects. So your phone does not emit ionizing radiation, and therefore it does not increase your risk of getting breast cancer.
Okay, so we have this huge machine here.
Yes.
It looks very intimidating. When you get in, you're like, okay. And then earlier on, I saw it doing the things, the turns and the all those things. So, yeah. So probably just help us understand what this is. You know, because we can see our dummy breast is already in place.
Okay.
Yeah. So what is this?
What is this?
Yes.
So this is our mammogram machine. So it releases low dose radiation. And I think it's very important also for women to be aware when they come in for a mammogram, who's going to do the mammogram for them. Yes. So in a radiology department, we have two groups of people. You have the technologist who is going to be taking the images, acquire the images for you. They're very well trained in doing that. They make you comfortable in as much as this will be under compression, but they make it a comfortable and pleasant experience. So the technologist will operate the machine, acquire the images, and then those will be sent now to me as a radiologist to make an interpretation. Okay. So in terms of the components of this machine, I think what's most important is up here is what we where we have the X-ray tube. So it's actually emitting the same X-rays that you use to, you know, if you have a fracture, the same X-rays that will be used. So they'll be emitted from this part. So it's housed in here, and the beams come through this opening that you have here. So they'll come down. This is a compression paddle, and this is a detector. So when those X-rays penetrate through the breast tissue, what is transmitted, some will be absorbed by the breast, and depending on the different tissues that you have, like the fat will penetrate easier than the glandular tissue. So when those X-rays, what's left after going through the breast is emitted on this other side and goes to the detector, that's what creates an image. And then now that image is transmitted to the screens, and that's what now we are able to interpret. So mainly you have two views that will be taken. There will be one where the breast is compressed in a top to bottom fashion, so craniocaudal, and then there'll be one where it's like a side to side but slightly oblique, which is called the medial lateral oblique view. So two images, and then you'll have the tomosynthesis with those views as well.
I see.
Yeah.
How long does it take?
So roughly, if everything goes well, it should be about 8 minutes.
Oh, really?
Yeah, because you're taking 4 views, and each view is going to take you roughly 2 minutes.
Okay.
Yeah.
Okay.
So 8 minutes, you're done. It's not that long.
And then, like you said, so it depends. The say, like women in their 40s, you might want to come once
annually, and then from the age of 55 every 2 years. This is because when you studied breast cancers and when they occur in different ages, you find that the more aggressive types tend to occur in the 40s, and so the more aggressive ones would be, you know, dividing very fast, and so you want to have a shorter imaging interval of 1 year, and the older the patient gets, the slower the cancers get, if I may use that. And so a cancer in a woman over 55 will probably be more slow growing. And so even if you have a 2-year interval, it's still enough time not for it to have grown too much that it spread into another part of the body. Yeah.
Okay. And then so there's mammogram for screening and mammogram for diagnosis.
Correct.
Is it the same approach? Is it different?
Okay, very good question. So for screening mammography, it's just those 4 views that I mentioned. For diagnostic mammography now is where, let's say you did your screening mammogram and we picked up something like, let's say, calcifications. So when we do see certain types of calcifications, we want to really magnify them, see them in closer detail. And so that's when now, together with the technologists, we'll come and do what are called like magnification views, so additional views. So it's like a more troubleshooting mammogram, the diagnostic one. You want to arrive at a diagnosis of what exactly is happening here. So there are times you may see an area where there's overlap, you're not sure whether there's a mass there, and so you just want to do a focused mammogram of that area with probably a smaller compression plate, not as big as this, so that you just see if that area spreads out or there's indeed a mass hidden in there. So the diagnostic mammogram also applies to like women who are symptomatic. So when a doctor sees a patient, they have a lump, they have breast pain, they have a discharge, they will send them for a diagnostic mammogram because they want to arrive at a diagnosis. But if you're not symptomatic and you want a checkup, then that's when you come for screening.
Okay. All right, so then as we bring this to a close, one would ask, are there any side effects associated with mammogram, and then also the cost aspect of it.
Okay.
What is the range, and is it covered by insurance or the what's called SHA? Just for people to know.
Okay. So in terms of side effects of mammography, honestly, I would say except for that momentarily compression, there aren't any side effects from the procedure itself. Because just put you there the same way you do a chest X-ray, you're doing that. It's just that momentarily being compressed that you'd be uncomfortable. So I'd say by and large, that's the main side effect. When it comes now to availability of mammography, first of all, every county in Kenya, through the MES platform, there's now a mammogram in every county. Before, there used to be just 11 analog machines, but after that rollout, they rolled out 47 digital machines, and then there are those ones which are in private practices. So there's quite a lot of availability of the mammograms. Coming to the cost aspect, I think it will vary with each institution, especially amongst the private hospitals. I'm not sure about how much it costs in the government, but like for me, one of the things I've tried is to try and cap the price so that it doesn't go too high. Most of the time it would be around 5,000 shillings, maybe up to 6,000 shillings. However, during the breast cancer awareness months, like in October, and for us also in February, we reduced the cost of not only the mammogram, but also the breast ultrasounds. And we don't forget the men. We also reduce the PSA cost and also the pap smear cost as well. So someone could come in either of these 2 months and get like a proper checkup for their breasts and for their cervical health.
That's really good.
So at this time you could get almost half the price, and I know many other places do the same thing in other facilities. So even if you're not able to come here, you live quite far, the other facilities who offer the same discounts. And with insurance companies, they do cover for screening mammography, and most of the insurance companies, we've not had a problem with that.
Well, that's good. That's really good to hear. So take advantage.
Take advantage
entire
of this
month of October, right? And just go get yourself. And like what you pointed out, that sometimes you can just treat yourself too, right? A mammogram. It's better to know than not to know, because a lot of women or even men, there's that scare. What if I go and I am told that the beauty is it will be caught early and event, right?
And there's one more thing that I wanted to add. Like one of the things we realized, like if you want to make this accessible, I don't require a patient to come with a request card from a doctor to say, please do a mammogram for this patient. Mammography in Aga Khan is a walk-in procedure. You come to the radiology department, you're 40 and above, say, I want to have a mammogram. From there, we'll give you a questionnaire where we'll collect the relevant information that we need, find out when you did the last mammogram so that you're not imaging you too soon, and then we'll perform it. Removing that layer of having to go for a consultation, again, is a way of also reducing the cost and making it more accessible to patients. So you don't really have to struggle, where do I start? Just come to radiology and get it done.
To go, because a lot of people don't know where to go. Dr. Rose, thank you so much
Most
for hosting us today. Dr. Rose Nduvia is a consultant breast radiologist right here at Aga Khan Hospital. Well, we'll say thank you to the entire team for hosting us today. And time now for you to take a look at this health tip.
This health tip, we focus on stigma among SGBV survivors. In case of sexual violence, we should support survivors access medical services. We should not shame them or stigmatize them or discriminate them. We should support them and not punish them, access care so that they can receive the necessary medical services and mental health support.
Well, we've come to the end of the show today as far as understanding mammogram for breast cancer, and the message can't be clearer. With a lot of misinformation and myths surrounding mammogram and breast cancer screening, the message is clear. First of all, mammogram does not cause breast cancer. It is safe. And number two, it is not painful. And number three, men too can go for mammogram. Well, all these insights, I'm pretty sure that You've learned a lot. But if you have any other question, feel free to engage with us on our social media platforms down at the bottom of your screen. And the fact that it is Breast Cancer Awareness Month, most facilities have subsidized their prices. So make it upon yourself to go to any facility, and especially if you are a woman over 40 years of age, and take advantage of the subsidized prices and get a mammogram done. My name is Winnie Lubembe. A special thanks to the Aga Khan Hospital for hosting us today. Until next week on Sunday, stay safe and adios.